The women that really get the short end of the stick are the women who are 10 years postmenopausal. And there's a couple of reasons for that. And I'm even going to go back to the WHI study, and just so women have an understanding of what happened there.
Electricast.
This episode of Transforming 45 is proudly sponsored by the National Menopause Show, happening October 17th and 18th at the International Center in Mississauga. The National Menopause Show is where science meets sisterhood, a trusted, inspiring, and genuinely fun weekend for anyone navigating perimenopause and menopause. You'll hear from leading experts, discover the latest research and wellness solutions, and connect with a community that truly gets it. Get your tickets at nationalmenopauseshow.com and use my exclusive code, Transforming45, and come as my guest. Can't wait to see you there.
Welcome to Season 4 of Transforming 45. I'm your host, Lisa Boate, and this season we're stepping fully into our power. The heat, the hormones, the heartbreak, the healing. This is midlife, raw and redefined. Each episode, you'll hear stories of humans who are rewriting the rules, reclaiming their bodies, their desires, their voices. This is where we stop shrinking, start shining, and remember who the hell we are. Because midlife isn't a crisis, it's an awakening. Let's get transforming 45. Electricast. Welcome to Season 4 of Transforming 45. I'm your host, Lisa Boate, and this season we're stepping fully into our power. The heat, the hormones, the heartbreak, the healing. This is midlife, raw and redefined. Each episode, you'll hear stories of humans who are rewriting the rules, reclaiming their bodies, their desires, their voices. This is where we stop shrinking, start shining, and remember who the hell we are. Because midlife isn't a crisis, it's an awakening. Let's get transforming 45.
Hello, and welcome to this week's episode of Transforming 45. Today's guest is one of my favorite kinds of humans, someone who's not afraid to ask better questions when the conventional answers don't add up. Cindy Dupuie is a functional medicine practitioner, nutritionist, yoga teacher, researcher, educator, and fierce advocate for women navigating midlife and beyond. Today, we're talking about what happens after menopause, what women should really be paying attention to, and how to become the CEO of your own health. Cindy, welcome. I'm so glad that you are here with us today.
Thank you, Lisa. And that was a great introduction because you hit all of the points. It's like, yes, you said it succinctly and beautifully. So thank you. Yes.
Thank you. I do try.
You did
that.
Thank
you. So I have been on the road a lot recently doing a lot of menopause education. And I will say one of the things that I have been really trying to emphasize because of what I hear coming from women in the crowd is, well, I'm past menopause. What's left for me now? So, Cindy, what do we need to know about post-menopause and why is it not getting the attention it deserves?
Great question. And I love it. There's a few reasons why. And I think, and maybe I don't even need to say this, but, people talk about menopause, post-menopause, and some people go, okay, we're in menopause for one day, that 1 day mark after you haven't had your period for a year, which is kind of an arbitrary mark. And then we're in postmenopausal. So menopausal, postmenopausal means the same thing in my conversation. So I just want to put that out there. And the women that really get the short end of the stick are the women who are 10 years postmenopausal. And there's a couple of reasons for that. And I'm even going to go back to the WHI study, just so women have an understanding of what happened there.
I will say I'm always surprised when I'm giving a talk and I'll say the WHI study and there's still crickets in the room and nobody knows what I'm talking about. So it's definitely worthwhile talking about what it was and what the results were.
Yes. So it was a big, large clinical trial back in early 2000s, and it was actually stopped prematurely about 2003. So what it was a trial or a study of was to study women on HRT. So there's 3 arms. So no hormone replacement, the arm that just had estrogen, and then the other arm was estrogen and progestin. And they took, I forget the numbers, but it was in the hundreds of thousands. Okay. Well, actually, it ended up maybe only being, I'll take that back. Maybe in the arm that they stopped was much, much lower. But anyway, it was a big study. And initially it was done to look at hormone replacement therapy and how it affects heart disease. So it was partially funded and established by the American Heart Association, which is interesting. So the problem with the study, there's quite a few different problems. And one is that the type of estrogen or type of hormones that we're using were not bioidentical. The estrogen was oral, and we normally don't do oral anymore. I mean, it's still out there. But usually we use transdermal or pellet or an injection, something like that. And it's usually bioidentical. So the estrogen that they used was made from urine of pregnant horses' mare. So it's called Premarin from the mare. And so those 2 factors right there are kind of an issue, something to hear, listen to, and to know about when we start hearing about some of the references back to the WHI study, which has set up the whole narrative for the last over 2 decades. Okay, so this is part of it. The progestin and estrogen arm, and you heard me say progest on purpose because progestin is not bioidentical progesterone. It acts very, very differently in our bodies, and it is a type of progesterone that you will get in birth control. And unfortunately, it's too often interchanged with the word progesterone. So when someone's maybe giving a result of a test or a study, they won't make that distinction. And you need to know that distinction because it is the progestin. It was the arm that was estrogen only. And there was a 20 to 30% increase in overall health, okay, which is estrogen that's not even bioidentical. That's oral, okay? And what happened in 2003, they were seeing just a tiny, slight possible increase in breast cancer in the progestin and estrogen arm. But you have to keep it in perspective in that it was statistically insignificant. It was like less than 1 in 1,000 women. Okay. So very few women had a small increase. And again, that was using progestin. That seems to be, if there is an issue, that's the issue.
It also was, so the population in that particular study were women who were further out in post-menopause and already had some pre-indicators for breast cancer. So
it could be that. Yeah, they weren't screened. Right. They weren't screened for breast cancer. They weren't screened for heart disease. They weren't screened for diabetes. So none of that was done. Yes. And the average age of the participants was about 62, 63. So you had women 75, right, who had been out of menopause, not on HRT, more than likely, for over 25 years. So in 2003 was when that panic result came out, and the press, the media ran with it. The doctors were up in arms, patients were up in arms, and all of a sudden women were going off of their hormone therapy. And where I think it might have been like 30 to 40% of postmenopausal women, might not be quite that high, were on HRT back then. It's less than 5% now, at least in the US. So a big, huge difference. Yeah. So they came off cold turkey, bless their souls. And since then, doctors have not had any training in HRT. They have not had any training in medical school, in perimenopause and menopause. And that's why we've been hearing crickets when it surrounds that up until recently, until, these doctors who have moved into perimenopause and menopause themselves and said, hey, excuse me, wait a minute, this isn't right. It's like, thank goodness for them. But it's taken that, and that's just been exploding the last 5 or 6 years, right?
Yeah. Although I will say I was reading Rachel Rubin's newsletter that I get this morning. So Dr. Rachel Rubin is a urologist out of the US who's doing some great advocacy work in this area. And she reported that the rates of hormone usage are still were still declining as of 2023.
Okay. You and I, and maybe a lot of your audience, right? Once you start looking for things, our algorithm just feeds us and feeds us and feeds us. And so we're getting all of this information, but there's still, and I'm surprised too, just like when you go and lecture and give a talk, I'm surprised at the lack of knowledge of the women that come in to see me. It's like, wow, there's so much information out there. That's interesting.
Yeah, I thought it was really interesting too, and definitely worthwhile bringing up. And I think anecdotally, I can still see why, particularly in this age range. Just last week, I was giving a talk, and there was a woman in the audience who was in her probably mid to late 70s. And I put my slide up that has hormone therapy on it to talk through the research. And I saw her face do this. And I said, "Tell me about your reaction." And she said, "Well, hormone therapy causes cancer. I won't be doing that." That study, although well-intentioned, has had repercussions for decades of women that is taking a huge amount of effort to unwind.
It is a huge amount of effort. And I would say that women currently who are anywhere from 45 or even 50 to 60, you're probably in a good space to get the support that you need with hormone therapy because you're within that 10-year period of going into menopause. And even extrapolating the information that they're able to extrapolate from the BUHI study, organizations like NAMS, or North American Menopause Society, and there's other societies in UK and Canada, have come back and said that, it is safe for this, this, and this, but it still tends to be the lowest amount for the shortest amount of time, even though NAMS did come out with their 2022 that made a very nebulous statement, but they made it. And that is, if it is called for or necessary, a woman may continue on her hormone replacement therapy 10 years out. There's really no reason for her to stop.
Yeah. And I think this is really important to stop and take a minute to talk about because it's a question I get a lot. And it is the window. Like how far out from my last period is it possible for me to still start HRT? How long can I stay on it? And is it too late for me? Right? Essentially is the question that gets asked a lot. And when we're talking about length of time, interestingly, this story has been coming up in multiple audiences. So I remember the WHI study because my grandmother had been on HRT, and I remember my mom hearing the story, the media, rushing over to her house and saying, "Mom, you have got to get off of HRT right now." And she did. And my grandmother is now 94. Lives in a retirement community, is still quite mentally acute, but her body has been failing her for a long time. New hips, knees, frailty, falls, all of the things that we now know are potentially results, right, of this. And I've had a couple of women in my audiences say, "You know what? My grandmother said no to her doctor and said, you're not taking me off of that. I like how I feel when I'm on it. No." And their quality of life is significantly better. Now, again, this is anecdotal information. I want to be clear about that. And it's also fairly consistent in what I have seen from my experience and the community that my grandmother lives in. It is a sea of women with walkers who are frail. And it breaks my heart because they deserve to have a better quality of life. And there's two key pieces of information that they really needed around maintaining their muscle and that misinformation about hormone therapy.
And you're right there with me. And I don't know, my whole body just kind of went like this when you started to talk about it because it does break my heart to see that and know that that's avoidable And one of the reasons why I switched my practice into men and women, I still love my men, but really focusing on this age group, menopausal, I do perimenopause too, was because I was watching my clients who had been with me for a while. So, I know how they eat. I know what they're doing, working out, their lifestyle and all that. And those pieces were pretty good, but we were still losing ground. I'm starting to see a little bit like osteoporosis, like, hey, and I'm seeing a little bit more of, not good metabolic numbers and more inflammation and more aches and pains and all of that. I'm going, okay, I need to pay attention to this. And then referring to what you just said, was that I was watching my contemporaries and I not going to the doctors like they're doing. And I'm not having the aches and pains that they're having. I'm more vital than they are. And I know that some of them eat really well and take care of themselves. But so yes, it really bothers me. And what our hormones do for us in our bodies. That it's like when you're going to learn to play an instrument, you have to have the understanding in the theory. So it's not just to stop the hot flashes and the night sweats and to help you sleep, although that's really important too. We have to understand all the roles, in particular of estradiol. It's not just for fertility. It's not just so we want to have sex, right? It's not just for procreation. It is every single tissue and organ in our bodies. So that means your digestive system. It means your brain. It means your mitochondria. It means your joints. It means your inflammation markers. It means your insulin sensitivity, your dopamine, your serotonin. So your moods, all of that, your muscles.
Yes.
Okay.
Yeah. I want to hop in here because this is the thing I hear more often than not is, oh, well, I'm postmenopausal now. That's all behind me.
Mm-mm.
Right. So what I've been saying back recently is I understand that your active symptomology may be behind you and there's still things going on under the surface. So can you speak to what happens the longer your body is without estrogen, progesterone, testosterone?
There's a cascade of things that can and do happen. And part of it's the genetics of the woman. Part of it is, her lifestyle too. But yes, you made a very good point. A lot of women go, okay, I got past it and now it's done. But it's the stuff that's below the surface, that iceberg, right? It's the stuff that's below that's bigger. I don't think women realize that the number one cause of death in postmenopausal women is heart disease. It's not cancer. Cancer, it doesn't even come up there. And then I don't think women realize, you break a hip, no big deal. You get hip surgery and all of that. This number might be changing a little bit, but still it's a number that's being quoted a lot. And I haven't looked into it otherwise. But women who have hip replacement, especially if they're 70 and older, only 1 in 3 will survive that first year. And it's not because of surgery itself. It's the immobility, it's the loss of dependence, it's the muscle loss, it's the propensity to have pneumonia possibly, and then the increase in UTIs as they're not moving and they have the catheter and they're in the diapers and all of that. Yeah.
Yes. And thank you for bringing this up because I wanted to make sure we talk about vaginal estrogen and the trends that we are seeing now with UTIs, right? I just want to circle back to if you were 10 years out from your final menstrual period, it is more challenging. So there's some research coming out showing that with a very nuanced and thoughtful conversation with your doctor, it's possible that hormone therapy may be an option. But again, it's going to be a lot of consultation. But within that 10-year window, hormone therapy is possible for you.
Hormone therapy is always possible for you.
Hey, say more about that.
I would love to say more about it. And I would love to share my own personal experience that has just been happening and unfolding over the past couple months. Now, so I've been on hormone replacement therapy. I went into early menopause at 43 and I was put on hormone, a very low dose because that's what you did then. It was a estrogen. What that means is estriol and estradiol. Estriol is very weak type of estrogen, but they were kind of doing that. They're still being cautious. So I was put on that at age 50. I didn't ask for it. I didn't know I needed it. And this doctor put me on it, and I'm looking back going, I could kiss her feet.
Yeah.
You know, I had no idea. And I was on, so that was 18 years ago. I've been on HRT for 18 years. And, when I really started to perimenopause, hormone, menopause, all of that, I mean, really studying it, finding out as much as I possibly could, what would make sense, connecting the dots, I realized I probably needed to change my type of hormone replacement therapy. And I did. I went to a higher estradiol, still cream, still compounded up until just recently, and still progesterone and all of that. So I went to a much higher dose. I did. And probably about 3 or 4 years ago, I'm very happy with it. So I have a doctor that I do have to pay out of pocket for him to see me once a year, and so he can legally continue to prescribe my hormones for me. So I am in an HMO, which is kind of, I guess, what you guys have across the Canada. But anyway, I'm Medicare HMO, and it's harder Medicare. You're going to get the help that you need when you're older. So anyway, I picked a DO, and a DO is an osteopath, thinking that she would have a broader view, right? What I was looking for is someone who would support me in taking hormones and be my doctor, all right? Went in there. One of the first things, she looked at me and she goes, "You're still on hormones?" And I went, "Yes, I am." And I said, "And I'm not going off of them." That was the first thing out of her mouth. Like, okay. And, so we had a little bit of a discussion, and then, she ordered up some lab work, and I had a few things going on, little things. And in between our time of coming back, meeting up again, I did message her, and I said, I just want to be upfront, and that is, if we can't come to some type of terms with hormone, I probably will need to move on. I mean, I know you care. I could tell, that she does look at other things, which I like. So when I went back in the second time, we did have a conversation, and she says, "I'm just not comfortable." That's legitimate. Okay. That's legitimate. And she says, "But if I refer you out to a gyno and they will prescribe for you, I'm okay. I just don't want to be that person." I said, "That's fine. That's reasonable. I'm cool with that." The interesting thing is, so her issue was not cancer. Her issue, so when we get older, usually it's heart disease. And it's going back to that oral estrogen that they used in the WHI study. And any other studies, there might be a little more propensity. I haven't seen any studies using transdermal that increases heart disease. So that was her concern. And, heart disease is really driven by inflammatory markers. Guess what happens when we don't have estrogen?
Inflammation.
Inflammation just goes through the roof, right? So that's going to drive it. And the other thing is, I had a full heart workup the year before. My inflammation markers are low. It's like, I don't get it. And it's even a little bit different because it wasn't like she was starting me from ground zero. I had already been on hormone replacement therapy. And I'm probably one of the healthiest 68-year-olds she has in her practice,
Yeah. I am with you. I often say, you'll be taking an estrogen patch off my cold, dead body.
Yes.
I'm going to the grave with my patch. And the 10 years I was referring to is starting. So
Okay.
if you haven't started,
you're still going to get a lot of pushback. And, I think you said that if we go into it cautiously, all right. But if you look at all the things that the estrogen does, yeah, we do want to look at a woman's inflammatory markers. We do want to look at that. But we would start it very, very slow. Okay. Probably the lowest dose would be reasonable because her receptors are probably pretty quiet.
Yeah.
You don't want to go, oh. So that along with progesterone and vaginal, right? You can start vaginal whenever and going back to UTIs.
Yes.
I mean, I have women, and I know you obviously are running up against it too, where women have repeated UTIs again and again and again, and they're on antibiotics. And if you would just take a little bit of vaginal estrogen, it's going to change that whole bacteria and that flora in that area. And, you're not going to have as many leaks. Just the whole thing just brightens up.
Yes. And this is such important information. And I feel like I hammer it with my audiences, but it's still not enough, right? The data that we're seeing now is that women are dying from sepsis, from UTIs, and people and healthcare practitioners don't understand the root cause, right? So they're treating the Band-Aid as an antibiotic, but that is not getting at the root cause.
Mm-mm.
So there are very, very few things that I say you must do this,
Mm-hmm.
outside of movement, nutrition, like those things.
Yeah.
Outside of those things, the only two things that I say are a must are vitamin D, especially if for us in our cold climate, and vaginal estrogen, because it is safe. It is safe for everyone for the most part. It is low.
Yes.
Which means it stays where you put it and it can save your life.
I like it when you say it that way because actually it can, and I've never stated it that strongly, but I'm glad you are. I'm glad you are because it really can on so many different levels. And I don't know about you, I have not had doctors push back on my women when they ask for vaginal estrogen. I haven't had that experience. And even women who have had cancer, hormone-driven cancer, I think across the board, the consensus is that they can also use the vaginal estrogen because it's such a low dose, especially if you do estriol instead of estradiol, you can get both, that they are understanding the benefits from that. But you are probably going to have to ask for it. If you are not getting it, that means you have to ask for it.
And you can use local estrogen when you are on systemic estrogen also. So this is the one place where I find people get pushback is they'll say, okay, well, if you're going to do vaginal estrogen, then you have to come off the systemic estrogen.
What? Really?
Yeah. Yes.
Wow.
Yeah. So that's an important piece of information for people to have when they go in, to know that systemic and local are two different things and they work in concert with each other. They're not in competition with each other.
No, they aren't in competition with each other. And, there's a difference in opinions amongst good doctors out there. And it's kind of like we have hormone wars and their opinions, unbiased and not all that other kind of stuff.
Yes.
And there are some doctors that feel like you should have vaginal estrogen, period, even though you're doing systemic. And it depends. I kind of come from the school is if we're getting enough systemic estrogen, we probably don't need the vaginal estrogen. So, yeah.
Yeah.
There is still a propensity, and I'm seeing this, is that the doctors are still doing low dose. I had to fight for mine. I got the highest patch that they'll do. And I mean, we can talk into lab markers, but I don't know if we've gone over the whole thing about 10 years after. So you do want to go slowly, mainly because the estrogen receptors are a little bit quiet and, we don't want to load everything up, and just see how you're feeling. And of course, if you have a uterus, you have to have progesterone. I would recommend taking progesterone even if you don't have a uterus because there's so many wonderful effects from progesterone, just like there is from estrogen. And so I recommend it for that. And I don't think women realize, and this is kind of a side issue here, but back in 1975, the FDA, the Food and Drug Administration, and in the U.S. approved estradiol as a prevention for osteoporosis. And, and then all of a sudden it stopped, and all of a sudden we have biphosphonates the same year that the 2003 study came out from the WHI. Biphosphonates all of a sudden hit the.
Yeah. So speak more. What is a biphosphonate?
Biphosphonate is the drug that's usually given to women if they are moving into osteoporosis. So what it does, so it's a reclass, and then reclass works a little bit differently from the pill form. The reclass is an injection, but the pill form can be an issue. So what it does is it prevents the breakdown of bone. Okay, so we have osteoclasts, which break down bone, and we have osteoblasts, which builds up bone, and we need both of those working. So the biphosphonates work just on the osteoclast, so it prevents those cells from breaking down. But it doesn't necessarily mean that we're making better bone. It'll be denser, but it doesn't necessarily mean that we're making better bone. And we can actually become more brittle. And it's not uncommon for the top of the femur to have a crack, and that's where the break is. Okay. For a woman who's been on a bisphosphonate for years. Now, they did have a class action suit, and I forget exactly when that was, because of, brittleness and the breaking of the femur bone, the top of the femur bone. And we can also have bone loss in the jaw area. So that wasn't, as I think there might even be a black box now on biphosphonates. Warning of this, but they didn't warn it in the beginning, so that's why there was a class action suit. But so it's not innocuous. You can only be on the pill form of the biphosphonate, and I think even the reclass, for 3 to 5 years, and then you have to come off of it. And then what? If you haven't, reduced your inflammation, it's not just protein and lifting weights. That's definitely part of it. But inflammation will suck our minerals out of our bone. What is our digestive system doing? Are we able to absorb our minerals, right? And by the way, the oral biphosphonate does have a problem. It can wreak havoc on the digestive system. So, when I get women coming in, and I do want to talk about a blood marker, just because we hit on bone, I just think it's really important.
Yeah.
Most women don't know about it.
Yes.
Okay, good. When I get my women in and they have full-blown osteoporosis, and I would like to also say when to get measured. That makes a big difference. And I do ask them, I said, did your doctor mention taking HRT or estradiol? Crickets, zero. No one. But we know that it will prevent it. And we also know, even though there have not been formal studies showing that it can help with the reversal. So what estrogen does, it slows down the activity of the osteoclast. Okay, it slows it down. So the bone loss will be less. Now, progesterone and testosterone will help with the bone buildup. So we have to have this yin and yang. That's what we had our entire lives. Our bones turn over completely in 7 years. So we need this. They're living, right? They're alive.
Yeah.
We don't think about that because we think when we're dead, right? We see these skeletons. Well, they're pretty dead, but they're still there. They're inert, right?
Yes. Yeah.
They're not inert. So that's really important. And I mentioned 2 markers that you can look for in serum. And I have my women order this. I don't know how easy it is for you to order it in Canada. And sometimes insurance will cover it, if the doctor's good enough, knows how to code it. Or you can order it on your own in the US. You can. And I've looked at different sites, and some of it can be a little pricey, but anyway, I think it's worthwhile because in the US, they usually do not do a DEXA scan, but every 2 years. And the first time that they usually do it is 65 years. Now, the biggest amount of bone loss we have is in the later part of perimenopause and menopause. So at 65, usually the bone loss is significant. It's like, wow. And now we have to go back and repair and try to build this back up. So young ladies out there, pay for it yourself. In the States, it's usually $100 or so to get a DEXA scan to see where your bone mineral density is, so you kind of have a baseline. And then there's different things that you can say to your doctor, different reasons, different risk factors that you can mention to your doctor. And I've had doctors kind of encourage me with different things when I've asked for different things. They said, so there's diabetes in your family? And she's shaking her head up and down. And there isn't diabetes in my family. But I said, yes, there is. Yeah. So it's okay. We learn how to work the system. We have to. So, yeah, go ahead.
And I know it can feel like we're working it, but really we're advocating.
Yes.
Right. We are
Thank you.
looking at preventative medicine rather than reactive medicine, because we know the outcomes are so much better when we catch things preventatively rather than waiting until we're in full-blown dis-ease.
Yes. Beautifully said. Perfectly said. I'm kind of a loud warrior, and just listening to you, I mean, you're a warrior too, but you've got this professional,
It's
more
what
professional way about you.
it's what comes from being a teacher for 20 years.
Is that what it is? Maybe I need to go be a teacher because it's like, oh, you just said it so great. Yeah.
Thank
I
you.
need to just be around you for a little while.
No,
I
I
mean,
love the way you put it out there. It's great.
we're good together. Okay.
Yes.
Yes, it is a way of advocating for ourselves, and we do need to learn how to do that. And the more information that we have, the easier it is to advocate because, you're hearing me say all these things. I'm obviously very knowledgeable, but guess what, ladies? I get intimidated when I go in. And I think part of that is I am more of a fight or flight person. I am. And it's like, okay, I don't want to get in a fight with her. So I won't say anything. And I will maybe go look for another doctor.
Yeah.
I won't stand there and go as far as I can with that one person. And this
I'm
time I did.
I'm so glad. And I'm so glad you brought that up because there is such a power discrepancy,
Mm-hmm.
right? When you are going in your vulnerability around something is happening with my body, I don't know exactly. And I'm going to the person who I've been told my whole life is the most knowledgeable and holds all the knowledge actually and knows my body better than I do, right? That's the story that we were very sold for
Yeah.
a long time.
Yeah.
And the more we know about the body and how it works, doctors train for a long time. They are hardworking people. There is nothing
Mm-hmm.
about what I'm
Mm-hmm.
saying that
Mm-hmm.
is blame or shame or any of those things.
Mm-hmm.
But we also now know how important it is for us to be in touch with our body and trust what it's telling us,
Mm-hmm.
right? Trust our inner wisdom. And with the rapid pace of how quickly we are learning now, it's impossible for anyone to keep up or hold
It
all the
is.
knowledge.
It is.
It's just impossible. And so a team approach is
Mm-hmm.
so important now when we are looking at our health and well-being altogether.
I'm glad you said that because it is a team approach. Because there is no way one person on your team is going to know everything and going to remember everything. So someone else on your team is going to go, let's look at this. And they're going to we all have our specialty or the way our lens is set, right? And just like with people, friends, right? There are some that'll always be right front and center pretty much. But then there's the others that, and some seasons we gravitate to them and other seasons we gravitate to the other person here. Same thing with our healthcare tribe. Yeah.
Yeah. Yeah.
Different modalities. So we do need at least 2 or 3 people on our team who can be another set of eyes, who can explain the risk and the benefit of whatever is being put in front of you so you feel more comfortable making whatever decision you make. And I do want to say this too, that ChatGPT cannot replace your team because you don't know how to give it the prompts that it needs.
Yes.
Okay. And, I had a very complicated blood work scenario that came in, and this client's been with me for a while. And I said, okay, I see this, and this. And it's really hard for me to put it in a cohesive way to talk about it. So I did put it into chat, but then I could feed it, okay, but this and this and this.
Yes.
And we did come up with a cohesive. So it was helpful in that respect. But you don't know what you don't know. None of us do. None of us do.
Exactly. And that is so important because it is something I've been hearing more and more is, oh, well, I'll just ask chat. I'll just ask chat. And that always raises my red flags for the same reasons that you just said. Like, can it be a tool that you use as a baseline? For sure. But don't rely on that, especially when you don't have a good foundational knowledge to know that's inaccurate or that has changed or, like in a different context, but I can't remember what I was doing, but I was fact checking. I was fact checking something.
Okay.
And it was an ad for a conference that was happening with our prime minister, who is now Mark Carney. And chat came back and said, oh, this is definitely fake because Mark Carney is not the prime minister of Canada. And I said, yes, it is. Here's the link to the Government of Canada website. And chat, even with that, chat came back and was like, well, he must not have been the prime minister for very long. And I said, it's been a year and a half.
Wow.
So those kinds of errors
Yeah.
are still possible and made. And that's in a fairly it's important to know who the prime minister is. But when you're talking about health, if you don't have that lens to be able to say, whoa, that piece of information I know is incorrect,
Mm-hmm.
it can be sending you down the wrong pathway. So
Definitely.
you still need humans on your team.
You do at this point in time, you still do.
Yes.
You still do. So yeah, for maybe just a surface you can, but then you still need that human element so they can connect all the dots and go, okay, for you, with everything else we're seeing here, this is what, you might want to think about. So
I wanted
going,
to,
Mhm,
sorry,
mhm.
I wanted to make sure that you got in the blood markers that we're looking for. So we talked
Okay.
about, because you put those two things together around when to be getting bone density, right?
Hmm.
So
Hmm.
we want to be doing that in earlier perimenopause so we have a good baseline to know where we're at. And
Hmm.
then what's the blood marker that we should be looking for?
The two that I like to see, one is called CTX, and there's a longer name for it. I don't know what it is. And that's looking at the bone breakdown, the osteoclast activity. And then I like to see something called P1NP. And again, I don't know what the long version is. And that's looking at the osteoblast, so the buildup of the bone. So we kind of want to see a balance of the two to see exactly where we need to be supporting the woman, right? So, lifting weights and doing things like that, that's more anabolic. That's more testosterone. That's more of that building up the P1NP. That's really helping, right? But if we're having this blowout breakdown, okay, of our osteoclast, it's going to be pretty hard to turn the ship around. Yeah, so we need to see both, and we need to understand why possibly the osteoclast is really being active. In this particular, I had a client who was like, it was around 650, something like that, in which we don't want it really over 300. And this is the one that I had to put everything together. And women don't realize, usually when we talk about thyroid, we think of hypothyroidism, so slow thyroid, but risk factors for bone loss would be hyperthyroidism. She was being overmedicated, all right? That was causing some of her bone loss. If you're a teenager and you've been on birth control pill possibly for a long time, especially when you're building up your bone, estrogen helps to build bone, right? And when we put a young woman or a teenager on birth control, we're preventing that spike in that estrogen during her
Right.
whole teenage years. And even when she's a young woman in her 20s and her 30s, they're not getting that spike. They're not getting that estrogen. And people don't make that connection between birth control. Yeah. And long term. Now, if it's a short term thing, yeah, that's okay. The other thing is if a woman is an elite athlete especially when she's a teenager, because again, that's when she's building her bone to about age 20, 22. If she's an elite athlete and maybe isn't having regular periods, okay, because she doesn't have enough body fat to do that, then that's an issue. Or let's say she's had a problem with, anorexia, something like that. Or being very, very thin and the body isn't making enough hormones for her to menstruate. That's another risk factor. Taking steroids and even inhalers like for asthma, like some people have been on them for years and years and years, that also will deplete and degrade bone. So these are risk factors that we don't even think about, that doctors aren't really thinking about. If we get a history on a woman, and we see these things, and it's like, oh, that's why it's really important to get a baseline, see where you're at,
Yeah.
midway
That is
through.
it's such important information, and why we need to be looking at our bodies as a full system rather
Yes.
than just the one component that we're treating, right? Okay. I could talk to you for forever, but a few rapid fire to wrap things up. What is the most underrated health habit that postmenopausal women should be engaging in?
That post. Really, at least walking, moving your body, getting outside and getting some resistance so you're not losing muscle. That's the biggest one for post for me.
What is the biggest myth about postmenopause?
That we're going to be miserable, that we're not going to be vital, and we're just going to shrink and lose our dependence. No.
Yes. So along that vein, what's one thing a woman can start doing this week to reclaim that vitality?
I say this with a little bit, not really caution, but more understanding, maybe. And that is, the thought of, lifting some weights or something like that might be just something that's just overwhelming, right? But even a 1 pound weight, 2 pound weight sitting down will do it. You're sitting in a chair, you get something in front of you and help push you up, using your legs, using your core, doing as much as you can and then leaving it be, and do it every day. So not huge things, but little things to your capacity. So I don't think it's ever too late. I don't think we're ever too old to start changing this around. And if you find that it's really hard for you mentally and emotionally too, because there is that component to it, then see if you can get a friend or hire somebody who understands the older body, who can get you going and support you. Okay.
Yeah, I love that. It is never too late to reclaim what you deserve to have felt all along.
I like
Cindy, thank you so much for sharing your wisdom with us today. All of Cindy's contact information will be in the show notes, so make sure you check that out.
Thank you, Lisa, so much for having me. It was so much fun.
Thank you for hanging out with me on Transforming 45. If you laughed, nodded, or had an oh wow moment, hit follow and share it with your favorite midlife human. Find me on Instagram at @lboat and keep those transformations coming.
Electric